So our next speaker is our former fellow Ian McNeill. His talk is on advancement in pediatric idiopathic scoliosis surgery.
Thank you to Chris and Vdara for inviting me back. It's a great honor to be here amongst the very esteemed faculty and thought leaders in the field. I have no disclosures. I was indeed one of the fellows 2 years ago, so it's good to be back on the West Coast. I'm now back home in Connecticut. I did neurosurgery residency in New York City and then came out west for my fellowship I've been very blessed to have some great mentors and along my career, and my mentor in residency encouraged me to do an orthopedic spine fellowship, which was one of the best decisions I had made. So I learned a few lessons during my year in San Francisco. Number one, it's actually okay to be seen leaving the hospital. When somebody actually told me to leave, I thought it was a test. So about a month late into it, I realized that it was actually okay. I also learned that there are more lifts than beyond the T-lift. In my residency, we did 100% posterior base. I did hundreds of T-lifts, and I probably could count the number of A-lifts or laterals on one hand. And so coming to UCSF and seeing the variety of approaches really expanded my toolkit and made me a much more versatile surgeon, which I think helps me take care of my patients better. And then lastly, again, we probably navigated, at least in the cases I did, I could count them on one hand. And so I came in with the kind of mentality that we don't need navigation, and definitely learned. I worked with six different surgeons who use enabling technologies differently. And so I learned various ways in which these technologies can be helpful. And again, it kind of expanded my mind in terms of what can be useful to take care of the patient. So today, I'll talk about augmented reality navigation and its use in spine. At UConn, we've done just over 400 cases. And admittedly, I was kind of a late adopter over the last 2 years. We got the technology just when I started. And when I first started, I stayed close to my freehand roots and then saw some unique applications. And over the last 2 years, I started to use it more so, particularly in the last few months, actually. So I'll talk about an overview and then talk about a few case applications. And so just to kind of make sure we're using the same language, I think we're all familiar with virtual reality. Commercially available, there's the Meta Quest. And so what that means is that there's a immersive artificial simulation that's a closed space. So you put on goggles and it creates a virtual environment through which you can interact, but it's all virtual. You're not interacting with any real object in space. Then there's augmented reality. A few years ago, Pokemon Go was a craze. And so really augmented reality is digital objects imposed in real physical space. So in Pokemon Go, you hold your phone camera, it takes a picture or video of your space, and then it imports or creates a digital object that you can collect. A lot of cars now will have heads-up display, so that's another example. So you either have your turn-by-turn directions or your speed, or even the radio station in your visual display. And then finally, there's mixed reality, which is where you have a digital object in space through which you can interact. And so actually, the manufacturing industry has incorporated this. So if you're building a complex object, a vehicle or something, you can actually have a virtual set of directions or guidelines. So imagine if you're at home cooking, and a lot of times you may have a cookbook or even your iPad. Imagine that was a virtual screen that you can now scroll through and even interact with to give you more information or act as an adjunct to make whatever task you're doing easier. So we're going to stay within the realm of augmented reality today. So why explore augmented reality? So as we all know, minimally invasive surgery is a term. There's a spectrum of what MIS surgery is, but I think I found that a lot of patients will ask about it. And so I think a lot of that push towards doing things through smaller incisions, there's like a patient demand for that. And so And patients want to know how accurate, what technology are you using in their surgery. And so because patients are asking about it, I think there is at least a responsibility to respond to that. We're always trying to be more precise with how we're treating our patients. And then, of course, the digital transformation, we all are attached to our cell phones. The amount of computing power in your hand is amazing these days. And I think in this generation, just the adoption of technology is very rapid. And so with new, there's just an opportunity to incorporate this. I also think during the pandemic, there was a lot of time, because the clinical practices were slow, there's a lot of time to put into thoughts in terms of how do we, there's a lot of opportunity to do more cadaver studies or doing other studies outside of the OR to implement technology. And so I think, as you can see here over the last couple of years, there's been more attention to augmented reality in spine surgery. I also think when you think about where spine surgery is compared to other fields, so when you compare it, for instance, to cranial neurosurgery, spine surgery is still catching up. So on the left, these are two pictures from my residency in a cranial neurosurgery OR. You'll have every toy you can think of: 4K TV, exoscope, optical navigation, 3D imaging. And so we're applying some of that into various cases, but in cranial neurosurgery, oftentimes we're integrating a number of these technologies together. So on the right-hand side, this is a planum sphenoidality meningioma, which is a skull-base tumor. And you can see that the way we used it in the case, we could actually plan the incision by projecting the tumor onto the skin. The yellow is the optic apparatus, the blue is a vein, and during the surgery, the heads-up display could be used to help you predict where you were based on relative to other important anatomy. And so I would argue that this helps the surgeon be a little bit more precise, perhaps safer. And so there's definitely, I think, unique applications for augmented reality in spine surgery too. This is actually a case report I worked on in residency on resection of a brain AVM using augmented reality. Oftentimes, augmented reality in cranial neurosurgery is mostly focused with tumor. There's been a little less usage with respect to vascular lesions, but again, just highlighting that, I think there's opportunity for spine to catch up. So what's the big deal? So this is a common scenario you see in an OR using navigation. We're all familiar with the fact there's an optical tracker. It has to see the reference frame that's attached to the patient, and then also the reference frame on the instruments we're using. And so if you notice in this picture, there's obviously an attention shift. No one's looking at the patient. And so obviously, there can be expert use of the technology, but, I think there's also some opportunity for fault. So what I think what happens when you look away, you lose some of the feedback that we use as surgeons. So we always are incorporating tactile feedback, auditory feedback, and visual feedback. And so once you take one of those elements out of the picture, you lose some of that proprioception that you develop over your career. And so also, you never know what can happen. I'm convinced that when you look away, that's when the E. coli gremlin shows up. You never know what's happening when you're not looking at the patient. So with augmented reality, you have, similar to CT guided navigation, there's less radiation exposure to the staff. You do eliminate some of the line of sight issues that you have with an optical camera. There's not the capital cost associated with the robot, and the system, at least with Augmented, is agnostic to any system. The trackers can be applied to an electric drill from any system. They can apply to the screwdriver of any system, the tap of any system, and so on. And beyond that, you're able to keep your eyes on the surgical field, and you incorporate all elements of feedback required for surgery, so auditory, visual, and tactile feedback. So, in this audience, we have several master surgeons, so I'm not here to kind of tell you how to do pedicle screws better, but when you look across the board, just a recap of where we stand with pedicle screw accuracy. This is a paper published by Hopkins, a review of 78 papers, including nearly 8,000 patients. over 50,000 pedicle screws, and they looked at the accuracy of freehand placement, fluoroscopy-assisted, CT-navigated, and robot-assisted techniques. And you can see here, at least according to this assessment, that CT-navigated was 96% accurate for overall pool versus freehand, which is 93%. Fluoroscopic assisted was about 92, and robotic was 91. When it came to thoracic screw breach rates, which were assessed separately due to the potential for morbidity, there was a 12% freehand breach rate versus the lowest was actually CT navigated versus robotic assisted. Now, when they looked at the number of screws that need to be revised, either by patient or screw based, it was less than 1%. So fortunately, in the majority of cases, it doesn't necessarily correspond to morbidity. But, when you think about, we're all driven to want to be, we're all perfectionists. Do we want to tolerate a 90%, 93% rate of accuracy? I think, if we got on a plane or and said we're going to get to our destination 90% of the time, we wouldn't be happy with it. You go to a restaurant and you get your order correct 90% of the time, it's not really tolerable. So I think, looking at how we can perhaps improve our accuracy is reasonable. There's been some initial results published in JNS Spine. This, granted, is a small cohort of only 28 patients, but in this early assessment, the screw placement accuracy was 98.5% for thoracic screws, 98% for lumbar S1 screws, and 90% overall. We'll have to see if this bears out when we look at a larger cohort of patients, but it does give you kind of some food for thought when it comes to augmented reality. So this is what augmented reality looks like. This is one product. There are other products on the market. This is Augmetics. And so you actually have a customized headset. It is based on your interpupillary diameter. There's a transparent visor on which the heads-up display is projected, and there is an integrated headlamp. This is another product on the market called VizAR. So just a similar setup, customized headset, transparent visor, and headlamp. The setup is somewhat familiar. So there's a tracker marker that's clamped on a spinous process, or you can do a perk pin. You get a intraop CT scan, and the instrument is navigated. So there's a reflective marker that's placed on your instrument. And so you can set up multiple instruments with reflective markers, and then the reflective markers are on the clamp. This clamp can be rotated, so you can rotate it so it's caudal, cranial, or facing away from you, depending on what you're trying to accomplish. And so you can see depicted here, both surgeons, the primary surgeon and the assistant, will wear the device. And so because there's two devices in the field, even if the primary surgeon's hands are being used in a way that blocks the optical or line of sight, because there's another device in the field or another head tracker in the field that will pick up see the optical tracker, and so you'll maintain the navigation, and so the system will bounce between the two. It's not a great way to depict what you actually see in the screen, but so this is actually a poor rendition. But what you do see is you see your typical axial and sagittal view, your 2D navigation, and then you have the option of having a 3D model. This is actually a very coarse representation. I would say, based on my usage, the 3D model is pretty awesome in that you can see the contours of the bone. You can see that you can appreciate the transverse processes. In many cases, you can see even the degree of detail of the mammillary bodies. And so you really, when you're doing MIS surgery and you're trying to cannulate a pedicle percutaneously, because you're looking at the field, at the patient, and you have a 3D model representation, it's almost like you are operating on an open spine because you're working through on a virtual model. You can toggle the 3D model off, and so in a open surgery, it's not as useful, and so you can turn that off. I think, so this is a couple pictures of me using it. So here you can see, and this is a percutaneous instrumentation. And then here, again, this is me working with a resident. At UConn, we just started a neurosurgery residency 4 years ago. And so our most senior resident is a PGY4. And a lot of our PAs are new grads themselves. And so in terms of, teaching applications, I think there's a lot of untapped teaching potential. I think it doesn't mean editorializing, but as we adopt more technology, more robots and navigation, I think residents will get less exposure to the freehand foundation. And so one of the unique things is you can toggle the navigation on and off. So I can turn the resident's navigation off, but maintain my navigation. And so I can coach them real time based on what I'm seeing and the trajectory of a screw placement. So I'll move on to a few cases. Again, as I mentioned early on, I wasn't really using much navigation, but there were a couple cases early on that I thought had called for navigation for cannulation of some difficult anatomy. And so these were kind of the first cases of using augmented reality, and then it expanded from there. So this is a 37-year-old female, had three prior operations culminating ultimately in a L2 to S1 decompression fusion. Was presented with severe mechanical back pain, bilateral L5 S1 radicular pain, and difficulty standing upright. She failed all conservative measures and intact. She worked as a machinist, and her goal was to be able to get back to work because she was no longer able to tolerate her workday. So this is her imaging. You can see she's hyperlordotic through the lumbar spine. And there's significant osteolysis surrounding the S1 screw. And the other thing the CT showed, there was no sign of osseous fusion. So this, her symptoms in my assessment were based on iatrogenic flat back syndrome, pseudoarthrosis. And so the goals were to stabilize the spine, achieve fusion, restore lordosis. And there's some evidence of L1-2 adjacent segment disease on our MRI. So consider surgical options. I elected to take the hardware out, do anterior column reconstruction with ALIS and a lateral prone transpsoas, inner body fusion. I did, so these are generally speaking the available enabling technologies, the fluoroscopy, obviously the robot navigation. In my case, I chose to bring in Augmetics. So this was the anterior column reconstruction, extended up to T12. And then one of the reasons intra-op, one option for the S1 screw osteolysis would just be to upsize to get a larger diameter screw. I couldn't even get a 9.0 screw diameter was still swimming in bone. And so I basically tried to get a better trajectory. One option, you can try to do that freehand, but it was very challenging to, and if you did it with navigation, what I found, even with the AR technology, I was still skiving into that old S1 trajectory. But ultimately, I was able to get a straight ahead S1 screw, so better fixation in S1. I took her down the pelvis, and ultimately she was more well balanced. She was discharged home post-op day 3 and returned to work at week 6. I followed her out beyond a year. She's still doing well. This is another case, a guy who had multiple lumbar surgeries, a prior hernia repair, who presented with severe intractable back pain, L5S1 radicular pain, also failed conservative management. And here again, you can see severe osteolysis at L5. One option would be to just skip that level and take him down to S1 or the pelvis. In this case, since he had the prior hernia repair, I didn't think that an ALIF was a great option for him. So the goal here was to stabilize the spine, achieve fusion, maintain his alignment. He was already well balanced. And so I revised the screw, this time taking a more anatomic approach, so avoiding the prior screw trajectory. So I brought in augmented reality and was able to get a better screw in L5. So the AR kind of enabled both redirection, medialization, and a bicortical trajectory. Then also navigated the S2ALR iliac instrumentation. And so this is, he also did well as well. So this, that again, goes kind of my entree to using it because of the difficult cannulation for those screws. And then, so I'll also talk more recently about 3 different cases: one a deformity case, a tumor case, and a trauma case. So this is a 52-year-old female, hysterogastric bypass of prior cervical thoracic lamina fusion, presented with mechanical back pain. There's a theme here: mechanical back pain, radicular pain, difficulty standing up, and weakness. In her case, she did have some distal lower extremity weakness. She worked as a masseuse, also wanted to return to work. Here you can see there's 34 degrees of lumbar levoscoliosis. On the MRI, it also showed severe L4-5 central, left L4-5 and 5-1 foraminal stenosis. SVA was 70. So the other unique thing here about her lower thoracic and upper lumbar particles were very small. So L1, looking at 2.2 millimeters. T10 was 3.5. So obviously in this audience, you could, I don't want to teach anybody how to do pedicle screws, so you could do extra particular screws. But for the sake of accuracy and time, and moving through the case, I think augmented reality was helpful here. We were able to cannulate all the pedicles well. And including, I navigated a JAM-CD needle. I do vertebroplasties and kyphoplasties at the UIV and UIV +1. So we were able to get a good correction here. So she's only 4 weeks post-op. At our hospital, we can't get inpatient standing full spine x-rays. So these were her discharge x-rays. And so I'll be following up shortly to get the full spine x-rays. So here's a tumor case. So this is a patient with invasive breast cancer, diagnosed a number of years ago, presented to me with severe thoracolumbar pain, inability to walk, and then she was essentially plegic in her right delt. This has been going on for 3 months. She was 1 out of 5 in the right delt, 4 out of 5 in the right bicep. NSAID gait, had positive colonus, so she was myopathic. And then she had these 2 fractures. She had a compression fracture at C5, as well as a compression fracture at T7, where there was also core compression. No significant core compression in the cervical spine, but there was severe foraminal stenosis due to epidural disease, likely contributing to her weakness. You also could see the lucency eroding the posterior elements of C3 and a spondylolisthesis. So I did not use augmented reality for the cervical, but I took her for stage 1 cervical surgery. I did a corpectomy, ACDF, and backed her up. She did well from that surgery, and then chose to address one of the issues. So bone quality was extremely poor. And when doing the ACDF, there's actually the bone just like pulled out at C3, the inferior end plate of C3. And so going into the posterior option, again, you could do this freehand, the thoracic surgery, but when we're dealing with poor bone quality, you have one skive, you miss one screw, particularly at the UIV or the LIV, that could lead to potential morbidity. So why not enhance the accuracy, particularly when the workhorse part of the surgery is potentially a corpectomy. And so, just decreasing cognitive load, moving faster, being more accurate. I chose to use AR for my pedicle screws and augment them. And then we proceeded with the corpectomy and cage placement. She's actually still in the hospital as of this morning. Well, she should have gone to rehab today, and we'll proceed with chemoradiation. And then finally, last case also from call this week is a 94-year-old male, history of diabetes, hypertension, heart failure, AFib on Eliquis, had a standing fall from height, presented with chest wall pain, intractable thoracic back pain, was found to have several rib fractures, a hemothorax, had a chest tube placed. He was on log roll precautions based on the finding of this fractures through the T5-6 disc space with some distraction. And then it's hard to see, there's an oblique fracture through T6 here as well. And you can see that in the stir sequence of the sagittal MRI. So this is a 3-column fracture. He was severely symptomatic. Every time he would be log rolled, he would be in agony. Not excited about taking a 94-year-old with this degree of comorbidities to the OR, but he could not be mobilized otherwise. And so, so in pre-op assessment, we had him assessed by cardiology. Obviously, had a frank discussion with him and the family. One of the other things is that you can see the bone was essentially translucent. And we look at the House using this is at least osteopenic, if not osteoporotic. And so once again, when you're thinking about cannulating pedicles, you really only want one pass. You don't want to keep trialing. And also, you're not going to have the same tactile feedback as good, healthy bone. And so this, I thought, was a case, again, also to bring in augmented reality for the enhanced accuracy, potentially. And so this is the post-op film. It shows the augment with cement at the top and bottom. Again, the bone was completely soft. And so I'm glad I did use the navigation in this case to, again, allow me to keep my eyes on the field, have an enhanced degree of visual feedback with the 2D navigation, because again, definitely the tactile feedback was not there, based on because of the poor bone quality. So the other interesting thing, it does give you the data. You do some data if you want about scorecards. So the team does keep track of the clamp placement, the number of spins, the navigation time, and so I would say this was under an hour for all the screws. This was all done by me. That was working with a PA who never really done spine surgery, so it was me doing both sides. And so I think it's reasonable for a 94-year-old. Exposure was about a half hour, closure about a half hour. It's about 2.5 hour surgery time for him. And he's, not surprisingly, having some post-op delirium issues, but he's been mobilized out of a chair. He's walked, which he could not do pre-op. So what's the verdict here? I think it's relatively new to the field, but here's my editorialization. I think some of the advantages, because you're incorporating all the feedback tools, auditory, tactile, and visual, offers potential incremental improvement in accuracy for instrumentation placement. As you can see, there's some enables cannulation, some difficult trajectories that would even be difficult with navigation because you need that added feedback of being able to see where your instruments are. There are some other unforeseen future applications. I think some of the disadvantages I've seen, there is a learning curve. So first starting out, it was frustrating as is with any new technology to kind of get the workflow down. But with time, it does improve. There are sometimes some line of sight issues. So even, you have to kind of learn how to optimize where the optical tracker is and kind of play around with that. So it's not as if there's no line of sight issues. You do have to make sure that your assistant is looking at the field and can see the optical tracker. With this current system, every time you bring an instrument to the field, you have to touch it to the tracker and verify. So those seconds add up. So definitely not necessarily faster than true freehand. The image quality can wash out. So when you're in the image, when you're using the 2D image, it's projected onto the skin. So often like the ioban or the drapes, I find that I put blue towels around the field because it shows up better on a darker background. And the illumination on the headlamp is subpar. So you sacrifice, you have navigation, but sometimes the illumination into the field can be frustrating because it can be difficult to see sometimes. There's no segmentation of anatomy, so in the cranial world, you can segment different tissue types, and perhaps I think that's a future application for navigation in general, but also augmented reality. So imagine if you could segment out the bone and then have the nerve in a different color, the spinal cord in a different color, a tumor in a different color. That may enhance our ability to be more precise. And then I'm finding with working trainees, and even if you're trying to teach them the freehand technique, they focus more on the 2D navigation as opposed to the actual field. And so that's why I started to turn that navigation off, so they can learn how to, operate with the tactile feedback and anatomic landmarks rather than just purely relying on the navigation. So future direction, I think illumination is important. Smaller headset footprint is light, but you can notice it over a long case. You will notice it over a long case. So the second generation is reportedly going to be smaller. I imagine one day perhaps having the wearing your standard loops and perhaps having that projection in our standard loop type footprint. Smaller clamp footprint as well would help with some of the line of sight issues. You still have to work around that clamp, and that sometimes can be frustrating. I think the tissue and landmark segmentation will be helpful. looking at the role for training education, and there's other roles beyond just pedicle screw augmentation. So there is a study that was just published that looked at using augmented reality for rod bending by touching each tulip and then creating a 3D model of a rod that you can match in your bending. So again, incredibly thankful for all the people I got to train with the UCF. I'm really honored to be back, and thanks again for the invitation to be part of esteemed faculty. Thank you.